obesity in this age group. Considering her age, BMI and the height, her BMI is much higher than the mean BMI, and her height is at the average, which is 0 and -1 ST. Considering the causes, the main causes will be the changes in the environment and behavior relating to diet and activity, such as increasing availability of energy-dense food which are rich in fat and fast food, processed food, and overconsumption of sugar-sweetened beverages, food advertising, and reduce energy expenditure and sedentary lifestyle, where she might have reduced physical activity and spending more time in the mobile phone, TV, computer, or screens. And it can also be due to genetic predisposition like family history of obesity, and there can be conditions like Down syndrome, Turner syndrome, and Prader-Willi syndrome. Considering the endocrine causes, there can be Cushing syndrome or Cushing disease, hypothyroidism, growth hormone deficiency, pseudo-hyperparathyroidism. There can be iatrogenic causes also, such as prolonged steroid therapy. Question B is, briefly describe the plan of management for her. To manage her, we have to take a complete history, including her birth history, family history, drug history, medical and psychological effects on her. We have to have a detailed dietary history to help to provide some insight in regarding her dietary habits, and also her detailed daily activity, like frequency, duration spent on physical activity, both at home and school. And also we have to know what are the types of physical activity she is involved in, and also about the sedentary behavior pattern. After taking the history, we have to do a physical evaluation. We can examine her and we can do anthropometry, general and systemic examination to look for any clinical features that are suggestive of the etiology. So we can manage her appropriately. Investigations are not needed in all the cases, but if we suspect endocrine causes, or we can do blood glucose level, lipid profile, and thyroid function test. Management is based on weight maintenance rather than weight reduction, because her height is normal at this age. With time, her BMI can fall into normal level. This is achieved by sustained changes in the lifestyle and behavior modification involving the whole family. So we have to do make her practice a healthier diet, healthier eating. We can advise her on having regular meals together with family and choosing nutritious food which are lower in energy and low glycemic index food. And we have to encourage her to increase vegetables and fruits. And if she likes to have snack food, we have to educate her on the healthier snack foods, and we have to ask her to reduce the portion size of her food, and we have to ask her to intake water as the main beverage, and to avoid sugary drinks, and meals should not be missed, and she should not be she should be advised not to eat all the time during the day. And about the physical activity, she should undergo a minimum of 60 minutes of moderate to vigorous physical activity per day. And also we have to do exercises in short spells, alternating with relaxation to overcome easy fatigability, and calorie restriction is important along with the physical activity. Sedentary activity should be reduced. The children, they should not be allowed more than 1 to 2 hours of screen time per day, and the child should be encouraged to engage in household activities. Automated appliances and vehicles should be used sparingly, like if the child can walk to small distances, it should be encouraged without using vehicles. and psychosocial support is also important. Parental support for psychological adjustment of the child, motivate the child to adhere to management, and parental education regarding healthy diet, importance of engaging in physical activity, and teaching the child to overcome psychological stresses. Pharmacological therapy is not recommended unless the child has complications like orthopedic complications, uh, uh, diabetes mellitus, hypertension, or gallbladder diseases. There are several other complications also. If that is involved, the child should go undergo pharmacological therapy. But in this condition, she does not need any pharmacological therapy. And we have to follow up the child in the clinic, assess her nutritional status and complications, and ask the parent to keep a record on child's diet and physical activities. That's all, sir.
Hello.
Yes, sir.
Hello.
Yes, sir. We can hear you.
Hello. Can you hear me?
Yes, sir. We can hear you.
Hello.
Hello. Yes, sir. We can hear you.
Hello.
Yes, sir. We can hear you.
Can you hear me?
Yes, sir. We can hear you.
A problem of connection. I can't hear you.
Sir, we can hear you,
Hello.
sir.
Yeah. I mean, it is coming and going. Something wrong with the connection here. I don't know whether it is the traffic.
We can hear you, sir.
Hello. Hello. Can you hear me?
Yeah. Can someone try talking to sir? Because
Sorry?
Yes, sir, we can hear you, sir.
Yeah.
We can hear you, sir.
Can you share your slides again?
yeah, sure.
Yeah. So now, before go back. Now, based on this, now you are making a diagnosis, no? Go to the previous slide. Hello. Yeah. Now, what are the main problems? I think identified here. Hello. Can you hear me? Hello.
Yes, sir, we can hear you.
Yeah. So now, what are the main things in this case scenario? The main salient points? You all are not responding because you all don't hear me, or is it? No, I want to go to the previous slide. In the previous slide, in this scenario, what are the main things in the history that we have to concentrate on? Hello. Can somebody say something? Asnya? Do you all hear me or not?
Yes, sir, we are hearing, sir. She's having some problems with connection, sir.
Right. So can someone then tell me something about the first, the scenario? What are the main things? You all should talk, otherwise we can't teach, no? This is a discussion, no?
Yes, sir. We have to mainly consider about her age.
Right.
And
so when
then,
the so age, then
her gender, she's a girl.
right.
And her BMI is more than the average. The average is 17, but her
Right.
is 24.
Right. Now you are seeing obese child, no?
Yes, sir.
Yeah. Now you said age is there, gender is there.
Yes, sir.
Then you have the BMI. Decide
Yes,
so how now BMI, how would you decide then? So the nutritional status will be determined by certain factors. Now the selection of the type of the yardstick or the measuring parameter will be determined by the age of the individual. Now if it was a 4-year-old child, what would you have taken to diagnose obesity?
We would have taken the according to the centile charts, we would have
Weight for age.
weight for age.
Weight for age.
Weight for height.
No, not weight for height. Below 5 years, it is weight for height.
Yes, sir.
Above 5 years, it is BMI.
Yes, sir.
Then you have, because based on whether it's a girl or a boy, your charts will differ. So when you see it's a child of 10 years, you have to get the BMI as the yardstick. Then you get the girl's chart and plot it on the girl's chart against the age. And then you will come across, okay, it is about +2 standard deviation. So then you call them as obese. If it was between +1 and +2, you will call them as what?
Overweight.
Yeah, overweight. Right. Yes. Then after the person is an obese child, then what is the next step should be? What is the next step? Sorry?
So that is why we want to interview our students also. Yes, sir. That is why you are this one. Madam.
Talk. Obese person. What is the next step you have to do?
She I have to say.
Hello.
Yes, sir. We have to see the weight for height.
No. Now we have got the BMI and we have
find the etiology for the obesity, sir.
in any condition. You have to find out the etiology, no?
Hypothyroidism, sir.
Because sometimes certain things to treat, to correct it, you have to know the etiology. You have to find out whether this is, now you have seen, now we know obesity is basically because of there is excess calories in the body. So what we intake should match the output, and there are certain factors that should be there for the other things in a child, where for example, growing and all. So for the growth reserve, if there is any calorie in the body for later use. So that means obese. So then of course, when you see that the height, usually we try to see whether the height is a tall person or a short person. So if the child's height is somewhere less than the median, it could be to some extent a short obese, we call it, because when a child keeps on eating, that they will put on a lot of weight. Sometimes we have to also bear in mind, sometimes some of these charts will not really reflect the Sri Lankan child, because we know some of our parents are fairly short. So we have to bear that in mind. If the both parents are also short, then of course the child also could be short. And as a result of that, he may not be really growing maximally to his age. But whatever it is, that the main thing is that it can be either due to excess of calorie intake, and especially if the child is also very tall, then it is definitely due to calorie intake, or there is reduction in calorie expenditure, or there can be diseases, as you said. So then you have to find out what are the main diseases. So can we go to the next slide, please?
Yes, sir.
Yeah. So main things are the increase in calories, what you have given in the first slide, where your consumption is less, but your intake of the child is high. And as a result of that, the child has a surplus of energy, which will be deposited as fat for later use. That is how we have evolved, because in good times we are saving more energy, and at bad times we are using them later on. So increase availability of, so now what we have come into is an environment which is contributing to obesity, what we call the obesogenic environment. Now you have quite correctly put out increased availability of energy dense food. Now high fat, high sugar containing processed food is there. Then the people keep on eating also too much, because the culture of the Sri Lanka is also that if there is food, you should eat all them. And you keep on eating, and the adults keep on children feeding, and ultimately they feed in excess. Then there is a bearing about the food advertisement. So the people are, or children are really pushed to take other types of food. And then the reduction in spending energy. 15, 20 years ago, children were playing a lot. But now their games or their toys have become either a computer game or some other form of a game, or the recreation has become watching television or things like that, rather than playing out. So the expenditure goes down, so less amount of expenditure, intake is high, there is a surplus. Then on top of that, there can be other syndromes. Now, family history of obesity. Mainly it is related to the leptin metabolism. You know, the leptin is a hormone which tells the body, the person, now you have enough stores, stop eating or stop taking. So if there is a problem of that signaling system, then most of these familial obesities are due to that. Then any of these syndromes can give rise to. Okay, next slide. Next slide, please. Yeah, so the endocrine causes. No, the previous one. Yeah, so endocrine causes. Now, endocrine causes, usually you should remember that their height is less, but their weight goes in the other way around. If there is a tall person, usually they are wasted. If there is a short condition, shortness is caused by an endocrine disease, usually they are obese. That is the common pattern. Or then the iatrogenic, which is again also endocrine mediated to some extent biochemically, you get steroid therapy. Okay, the next slide. So how would you plan your management?
No, not right.
Now the plan of management is that you have to see whether there is any other underlying genetic or endocrine problem, or whether it is a pure increase in the food intake with reduction in the expenditure. So what you have done here is quite right. So you have to have a birth history, because there can be sometimes GDM precipitated birth. So obese birth children could remain as obese also. Then the family history of these obesogenic conditions. Then the medications and psychological effects. Sometimes they can keep on eating. If their diet is increased, you have to reduce. They may be lacking in certain fiber containing low calorie rich, calorie containing food. So those have to be altered. Then the detailed activity of the history, what they do, how they spend time, things like that. Now, sometimes they may be doing 1 hour of physical activity. But of course, if they are seated in one place and watching television for 5 hours, 6 hours, then of course, all that is gone. Then sometimes some people will watch television while eating something, a snack, unnecessary. So all that have to be, you have to directly or indirectly get those information and correct it. Because you can't really prescribe a work plan for these children. You have to change it within the system. So now, because they are used to certain plan, and if you prescribe, okay, this is the diet you should be taking, this is the activity that you should be engaging, they will hardly engage. And they may do it out of enthusiasm for a week or two, but definitely after 1 month, they will stop it. So it is important that you provide the correct advice within their normal behavior. So you have to alter that. Okay, the next slide. Right. Then complete physical evaluation, anthropometry, genetic and systemic examination. So this will, and the anthropometry. Now anthropometry, apart from you are doing the assessment and telling them the child is obese, also you should tell them how much they are obese. Because now if you're a parent, you say that the BMI is 25, you should come down to 20, people may not really understand. But if you tell them how much their current weight is, okay, we'll say 50 kilograms, but you have to come down to 38, then they will appreciate, okay, the child has to lose 12 kilograms. Because people does not perceive the BMI, what does that mean? But of course, day-to-day measures like kilograms, they will understand. So it is always a good practice that once you will know from the chart what is the median, or at least the +1, because we know we have to keep them below +1 standard deviation. Otherwise, it will be overweight also. So in that case, what you will do is, you will calculate back. Now, if you have the BMI and if you know the height of this individual, then by cross multiplication, the BMI multiplied by the height square. So for the particular height of the individual, there will be a ideal BMI, and for that ideal BMI, you can calculate what would be the appropriate weight. And so you can tell that. So then the parents will, and the child will also understand, oh my God, I am 12 kilos more than what I should be. That will be a more better way of looking at it rather than that. Then, of course, the other physical evaluation is the acanthosis. Because acanthosis is now, you can see a lot of prominently it is available. It is seen on children. And acanthosis means the earliest sign of a child is developing insulin resistance. So you have to correct that. And then the good thing is, whenever the body fat comes down, the insulin resistance gets better. And as a result of that, the acanthosis will go down. So if a person loses weight and the acanthosis comes down, then of course that is and where the point the acanthosis disappear, that would be the point where they would be having the correct body weight. So that will give a good insight to these people, and they will help to reduce the that will be itself an incentive. Even without a weighing scale, you can find out what the body fat should, or what is the ideal size should be when the acanthosis disappears. Then you have to do the investigations, right, to identify the etiology on one hand, and also to see the morbidity that it has caused. So you will do a fasting blood glucose level. You can do a lipid profile. Hello.
Yes, sir, we can hear you.
What is TFT?
Thyroid function test.
Well, thyroid function test you can do, but it should not be really a routine thing, because you can see the other features of hypothyroidism. But the more important thing is to do the liver functions, mainly the ALT and the AST level. Then you can also do an ultrasound scan to see whether there are where there is any fatty liver or fat deposited in the liver. And then sometimes the glucose level indication. And if you do a OGTT, that would be much better, because you are giving a calculated amount of glucose and a challenge, and that will give a better picture. So you can add on to this the liver function test or the ALT-AST, and then 2-hour OGT. And the 2-hour value is more than enough. You don't have to do half-hour value or 1-hour value, because your interpretation based on 200, it is impaired glucose tolerance, and if it is more than 200, it is frank diabetes. Then the weight management. So 2 things, you have to correct the weight, as well as you have to correct any abnormal metabolic problems. So you have to, so that's where you say this is the goal that you should be bringing down. And now in children, of course, sometimes you may insist that they should bring down their weight at the next visit in about 2 weeks or 1 month, but may not happen. The first primary goal is, okay, you maintain the weight in 2 weeks when you're coming. That itself is a big achievement. And then you can gradually cut down, maybe about 1 kilo a month, if you can bring down. Because one thing is, if these children, in your examination, you also have to have an idea about the maturity, whether they have gone through the pubertal growth spurt. Now, if a child has not gone through the height spurt, then if we can maintain the weight, the child's BMI will come down, because he gains height, remains, their BMI will come down. But if it is a child who has passed the growth spurt, if it is a girl who has a 10 menarche, if it is a boy now who is almost have completed his height spurt, then of course keep right. So that way you have to see. So you have to do that, and then you have to identify and make the changes. Go on to the next slide. So the diet will provide, okay, about 8 kilocalories, you can 80%. Then high fiber diet, low glycemic food, non-fat, restricted refined carbohydrates. So mainly what you have to say is the properly structured diet at proper intervals, not eating here and there, and also to reduce the volume. Mainly the volume is the main thing, so you have to cut down. So if you can give a measured amount to eat, that would be the best. Then physical activity, you have to make sure that they burn their calories. So they can either engage in minutes a day, and then also they should be short spells of alternative things good, and calorie restriction is so their sedentary behavior, seated in one place, spending a lot of time, they should stop. They have to keep on walking. So the simple things like using a lift or escalator, if they can stop, you have to tell them. If they can walk to the school or cycle to the school, you have to tell those things. So like that, you have to get them doing more and more work. In the next slide.
This is the next slide.
Next slide.
Yes, sir. This is the next. This is the
This is
previous.
the last
and this
one.
is-
Yeah, sorry.
Yes, sir.
Sorry. Sedentary activity. So you have to reduce screen time as much as possible. So this is one of the biggest problems, screen time. Then of course, yes, you have to have a good psychological support, because this is change of lifestyle to somebody who is not really ill actually. For them, they are not ill. So you have to make sure they, as well as the family's lifestyle, because if there are 2 other children, they also can't be eating a lot. And then you can't keep one child without eating. So everybody has to agree and follow that. Then of course you may go for pharmacological therapy in resistant cases. So in children, of course, first you treat them with the diet and the physical activity and cut down the sedentary behavior. After about 3-6 months, still no improvement, it keeps on going. They may have impaired glucose tolerance. They may be having a little bit of diabetic, that type of a thing. Then of course, they may be have hypertriglyceridemia, hypercholesteremia. Liver may have fatty liver with elevated liver enzymes. Then of course you have to think about starting on treatment. And the best up to now is what? What is the pharmacological agent we can use?
Orlistat.
Orlistat.
Orlistat can be used, but Orlistat has a little bit of a problem that they will pass a lot of greasy stools. So it is very uncomfortable, especially for adolescent children. Then
Metformin, sir.
Metformin.
Metformin has proven it will not bring down a large amount of the weight, but it will help in reducing the insulin resistance, and then reduce the appetite and gradually come down. So you diagnose. So in summary, you diagnose obesity. You try to find out the etiology, and then you try to also find out any comorbidities. Then your management plan is that you will sort of try to treat the underlying problems. You will try to give them a target. If the child is prepubertal, then you can actually try to maintain even the weight, where with the height they will get a better BMI. But if it is a child who has passed the growth spurt, you have to invariably reduce, because childhood obesity will persist into adult. And then, so you improve the diet plan, you improve the physical activity, you psychologically adjust them, because it's a whole behavior change. And then, of course, if there is morbidity, and after about 3 to 4 months or 3 to 6 months, if there is not much of improvement, then you will consider going on for pharmacotherapy. Sometimes, very rarely, in older children or adolescents, you may have to consider bariatric surgery if it is very, very high morbid obesity. Even the BMI may be around, then of course you may have to consider. So surgical option is rare, but it is not absolutely non-one. It is existent, and people may use. So any questions? Any questions on this? Right. Okay. Then can we go to the next presentation?
Thank you, sir, and sorry for the delay and the connection issues.
Yeah. Hello.
Hello.
Right.
Hello. Good morning, sir.
Yeah, next slide.
Yes. This is our scenario. A 15-year-old boy with a beta thalassemia major is being investigated for the short stature and low BMI. Height is 135 centimeter. It is less than 3 standard deviation for his age. BMI is 14. The mean BMI for 15-year-old boy is 18.5 kilogram meter minus 2. Mention the possible causes for these findings in him. And the second question is explain how these issues could be managed in him. So this is the answer for first questions. They mention the possible causes. So first, the inadequate management of the thalassemia causing the chronic anemia. The second one is an iron overload causing the endocrine abnormalities such as growth hormone deficiency, gonadotropin hormones deficiency, hypothyroidism, and the hypoparathyroidism. Uh, the next one is a skeletal dysplasia and the retardation of the bone growth due to the thalassemia itself, and iron chelation therapy. The next one is the nutritional deficiency due to the inadequate intake. Next answer is psychosocial deprivations and the familial causes and the constitutional growth delay. Next answer, the next one is recurrent infections due to the chronic blood transfusion and the IV access and the splenectomy. Next question is how to manage these complications. So we have to follow the multidisciplinary approach in management of these conditions. So the multidisciplinary team should include the pediatrician, hematologist, nutritionist, endocrinologist, psychotherapist, nurses, caregivers, and the social workers. So first we have to give the regular adequate blood transfusion. We have to consider this issue. So this will improve the nutrients and the oxygen supply to the tissues, leading to reduce the iron absorption from the gut by reducing the iron overload. So this will ultimately give the correct anemia, suppress the extramedullary erythropoiesis, and improve the physical and the mental well-being, and maintain the growth and the development. Next, we have to do proper management of the iron overload. So this will prevent the cirrhosis of the liver and the heart and the pituitary and the pancreas. Then next we have to do the improve the nutrition. So advise to have the balanced diet with adequate calorie, the micro and macronutrients. Next, monitoring the complication of the hormone replacement. So we have to consider the endocrine part. The height, weight, and the growth velocity should measure 6 monthly at the clinical visit. Then we have to investigate the thyroid stimulation test and the free T4, the serum calcium level and the vitamin D level, the parathyroid hormone level, and the glucose tolerance test. So hypogonadism should be monitored. So we have to do the Tanner staging in every 6 monthly after age of 10 years. Then bone assessment, DEXA scan from the age of 10 years annually we have to do. Next, cardiac monitoring. So we have to do the 2D echo and the ECG at diagnosis and then annually. So each complication should manage accordingly. According to the growth, correct the growth hormone deficiency by growth hormone therapy. This will stimulate the endochondrial growth and the bone mineralization. So induction of the puberty at proper time or the sex steroid replacement in the hypogonadism. Cardiac referral and the anticipate the cardiac failure. So we have to do the transfusion should give over 4 hours with the furosemide cover. So we have to maintain the pre-transfusion hemoglobin level 10.5 gram per deciliter, post-transfusion hemoglobin level 14 gram per deciliter. Prevention of the recurrent infection. So we have to immunize these patients with the pneumococcal, meningococcal, Hep B vaccines, and the lifelong penicillin prophylaxis after splenectomy should be continued. The prevent the blood transfusion related infections. So we have to screen the blood before transfusions. And the psychosocial support we have to give. We have to have a good discussion with the family and the social workers in his surroundings. So then goals of the management are the maintain the optimal nutrition status, avoidance of the iron overload, management of the anemia, slow down the progress of the disease. So regular clinic follow-up and the good compliance important for the better outcome.
Right.
Sir.
So Yeah, so in the scenario, you can see that now in a child, although thalassaemic, you can't forget the simple nutritional deficiencies also. So you have to have that in a back of your mind. And the disease complication itself will be there. And then as a disease complication, the food intake could be low, or due to normal other factors, the food intake could be low. So you have to see what are these. So then go to the next slide. So, okay, these things are right. So familial and constitutional delay is something that you also have to bear in mind, because they can be even, although the child is looking very short, what we are using is international growth charts. So the parents also, we could be small. So you have to have the mid-parental height and also have some amount of idea whether this child is within the genetic potential or whether it is outside the genetic potential. Okay, then next slide.
Next one, management, sir. Complete.
Okay, you can have everybody, you can get the inputs from these people, and then, but mainly a pediatrician or somebody, single person should be knowing everything about the patient and get the help from the others. So the team leader, usually a pediatrician or a physician in old age, have to take the lead, and others would fall in line with them, rather than nobody knows anything, situation can't come up. Okay, then next slide. So blood transfusion, that is very important, that as you said, 10.5 should be the minimum. So you have to have an idea, and sometimes these patients come and in a mighty hurry they have to go, but they do not do post-transfusion. So what will happen is they will get a transfusion and they will end up post-transfusion maybe 11.5 or 12 or something, and then next time when they come it will be 9.5. So that is no good. You have to make sure that you optimally maintain, and if you properly maintain, their disfiguring features, everything will disappear. So iron chelation is also very, very important. You have to give them iron poor diets. And then also do the key. You have to make sure, you have to find out something which they will comply, because sometimes some children do not like the subcutaneous desferrioxamine. So then you can go for a proper oral chelator like deferricerox or deferiprone, depending on the profile that the child will be tolerating. Then, okay, these things should be done on a periodic basis. And most important is that you have a record system. Otherwise, you will not know what you have done. Then any other way where you can, next slide. Any other way you can find out iron overload? What are the main two organs we are worried about iron overload?
Heart and the pituitary.
No, not really.
Pancreas.
No.
Thyroid.
Nope.
Liver, sir.
Liver and
Heart.
Heart.
the heart. So what is the best way now to detect iron
Fatty scan.
overload in those two organs? Right? So the MRI scan will help you to identify whether there is iron overload and then act accordingly. And usually after, I think, 10 years, they do it that way. So the other investigations and things what you have given is quite right. And so those things have to be done as part of the management of the thalassemia condition. Okay, go on for the next part. So then, yeah. So all this, then the important thing is the diet. So diet, you have to make sure that the adequate diet is taken, because anyway, they are in and out of hospitals, they are running here and there, then there's psychologically also low. So make sure that they will be taking enough calories. Can we go to the first slide, please? No, the previous one, yeah. So what is the nutritional status of this child? Did you ever worked out? How would you label this child? A thalassemia child with complicated from nutritional point what?
Chronic malnutrition due to stunting.
Malnutrition, okay.
Severe,
If you give specific words,
severe standing.
severe stunting, is that all? Is that all? Where is
Indicate
BMI?
chronic malnutrition.
No, right, that is indicating. So stunting is there, and what about the
Underweight.
BMI?
Severe standing with underweight.
You don't call underweight because here it is wasting. Underweight is weight for age parameter. Wasting is where in relation to the height of the individual, the weight is less. And usually always it is the best indicator is to use weight for height, standardized weight. Either weight for height in children less than 5 years or BMI in children over 5 years. So if the BMI is below -2 standard deviation in the BMI for age chart, you call them as wasted children. So it is a stunting and wasting, which denotes chronic and acute malnutrition. So you have to see it. So the BMI not only used for overweight obesity diagnosis, also for wasting diagnosis or wasting diagnosis in children less than 5 years, children more than 5 years of age. So that is the only completion that you have to do in this slide. Other than that, the things are okay. Any questions?
No, sir.
Right? Anything?
Yes, sir.
Okay. Then can we go to the next one?
Yes, sir. Thank you, sir.
Yeah, you're welcome. Who is the next presenter?
I'm going to present, sir.
Yeah, so okay.
This is our case, sir. A 1-year-old girl was diagnosed to have hyperplastic kidneys. For 1.5 age is 9 kilograms. Describe the long-term management, including the dietary plan. So here the causes for reduction of weight and short stretch are as following. First one is inadequate food intake, secondary to anorexia, altered taste sensation, nausea and vomiting due to uremia, and due to intercurrent illness, dietary restrictions and socioeconomic status could be. The next cause could be increased metabolic demand due to chronic inflammatory status and superimposed illness. And next cause could be uremia causing growth retardation. Other causes are endocrine causes such as vitamin D deficiency causing reduced bone growth, and hyperparathyroidism causing bone destruction and insulin resistance. And anemia due to erythropoietin deficiency, bone marrow suppression by uremia, inadequate food intake, and inadequate iron absorption due to gut edema. Therefore, the care process requires multidisciplinary team approach, which includes pediatrician, nephrologist, nutritionist, endocrinologist, psychotherapist, nursing officers, caregivers, and as well as social workers. The goal of management are maintenance of optimal nutritional status, aid the growth and development of the child, avoidance of uremia, management of anemia, and slow down the progression of disease and prevent further complications. Dietary modification and nutritional optimization is the main management concern. Nutritional management by nutritionist experienced in pediatric renal patient is recommended. The child should receive estimated energy requirement, which is individually adjusted for the physical activity level. Although protein restriction is required, dietary protein restriction is not suggested, considering the growth and development of this child. And child should be provided with high biological value proteins such as egg, meat, fish, and milk, and increase the probability of food to overcome the anorexia, palatability. Sodium, potassium, and phosphate rich food should be avoided. Children with CKD can become deficient in water soluble vitamins either because of inadequate dietary intake or dialysis losses. So we have to this should be routinely, we have to supply routinely. Zinc and iron supplements should be added only if deficiencies are confirmed. If oral caloric intake remains inadequate or weight gain or growth velocity are suboptimal, enteral tube feeding should be considered. Supplemental feedings may be provided via a nasogastric or gastrotomy or gastrojejunal tube. And as other management goals, we have to minimize intercurrent illnesses by proper immunization according to EPI schedule, and prevention of CKD mineral bone disease by normalize the mineral metabolism with the goal of improving, reducing bone deformities and fragility. This is done by low phosphate diet and high calcium diet. We have to reduce the potassium level. We can give phosphate binders can be prescribed such as calcium carbonate, calcium acetate, or cevilemer. Correction of anemia by iron supplements with vitamin C and folic acid with targets of serum ferritin more than 500 and transferrin saturation more than 30%. Regular growth monitoring is essential as short stature is a main sequelae of childhood chronic kidney disease. Therefore, height and weight monitoring is clinic follow-up clinic follow-up is essential. Childhood remains less than -2 SD with good medical treatment and diet can receive recombinant human growth hormone. Also, monitoring for other electrolyte imbalances and endocrine abnormalities and correction should be done accordingly. Definitive treatment is renal.
Shall we go to the first slide?
So one more slide is there.
Yeah.
Definitive treatment is renal replacement therapy. Parents and caregivers should be explained regarding renal replacement therapy and counseling is necessary.
Okay.
This is the first slide.
Yeah, so the main thing is now this is a child who may be previous slide. Yeah, so he's wasted, he could be also stunted, and then and having a underlying renal problem. So it is now when you see a wasted child, you should not only grab the nutritional deficiency, but the illness itself, you have to think about it. So then shall we go to the next slide? The next slide. So these are the main reasons for poor intake as a result, which has caused the reduction in weight and height. Socioeconomic thing as well as even psychological stress could also be taken into consideration, because a child who is really ill will not be psychologically cheerful, happy child, and that will also adversely affect because he is unduly under stress environment, internal work adversely, because psychological deprivation or psychological stress causes problem. So these are right. Okay, yeah, so go on to the next one. Next slide. So anemia is something you should remember. So anemia has several mechanisms in a renal failure child. Erythropoietin being the primary thing, then marrow suppression. Then the food intake is also inadequate, more than inadequate iron absorption. You also have to remember that they can have losses of iron, especially several ways. One thing is mainly they can have a uremic ulcers or uremic gastritis or gastropathy, where they can lose blood from the GI tract. And also these children will be undergoing a lot of blood investigations. So in those places, they will be drawing a lot of blood and there can be loss of blood because this child is 1 year, isn't it?
Yes, sir.
This is a 1 year-old child. Yeah, so in such children, drawing about 4-5 ml blood even is a fairly large amount because the compensatory mechanisms are not good. Now his erythropoietin secretion is poor. Bone marrow functions are poor. It is not like in a normal child you are drawing 5 ml versus in a child of this nature drawing 5 ml. So that also remember, back of your mind, frequent blood investigations also is a cause of iron deficiency as well as, anemia as well as iron deficiency. Okay, then next slide. Yeah, so this is the team, right? Okay. So run through the other slides, please. Yeah, optimal nutrition, growth development, uremia, management, anemia, slow progression. And then, so, right. So goals of management nutrition wise is to improve his quality. And now as we are doing fair amount of renal transplants, we also have to make sure that we get the child nutritionally optimized before the next slide. So dietary modifications, all those things are right. So dietary restriction or such considering the growth and development should be provided. Higher values of protein, egg, meat, fish and milk. But sometimes you have to make sure that you don't give large amounts of unmodified cow milk because they can be having, what is the problem? What is the problem with unmodified cow milk? Anybody? Hello, do you hear me? Hello?
Yes, sir, we can hear you, sir.
Do you hear
Hello, sir.
me? Yeah, when you give a child unmodified cow's milk, what would be the problem? What is high in cow's milk? It is not good for a renal failure patient.
Potassium.
Increased renal solid load.
Okay, one thing is correct. Nitrogen as well as sodium. Right then?
Potassium.
Casein levels are in cow.
No, it's phosphate. They have high amounts of phosphate. So that is not good because we know renal failure patients have high amount of phosphate. That is, so you have to reduce phosphate intake. That is one. Then the other thing is you will tell them to take sprats. But you all know on both sides of the body of the sprat, there is mainly because it contains high amounts of phosphorus. So the phosphorus is reflecting and glowing. So that causes again hypo. So tell the parents to remove those two small lines. You can pull it out like a plaster to remove that and clean and then cook the sprat. Otherwise, sprat is good because it has calcium and it has protein. But to get rid of the phosphate lines on either side, and then because that you have to bear in mind that now milk and these things, although they are good in one component of the nutrients, there will be issues with the other components. Okay, then next slide. Illnesses, okay, prevention, mineral bone density. And especially you also have to mention about using proper filters for water, because we know that the water in the country now is not very good. It is contaminated with a lot of agrochemicals. It is contaminated with a lot of heavy metals. So boiling the water alone is not going to be helpful. So you have to use some form of a proper charcoal containing filter where it will absorb most of the heavy metals and toxins in that. So that is also something you should bear in mind. Right then. Next slide. Yeah, growth monitoring. So yeah, okay. Then next slide. Yeah, can we go to the previous one? Previous slide. The one before. One before. Yeah. So on the feeding types, the nasogastric, gastrostomy or gastrojejunostomy. Which one would you think the best would be for this child? Anybody? Hello?
Peg tube, sir. Gastrostomy tube.
Yeah. Because the nasogastric tube, every 2 weeks or so, you have to change it. There is a high chance that the child can pull it out. And sometimes the tip of the tube can curve and causes aspiration. Then the gastrojejunostomy, that is in the jejunum, which takes you have to give small feeds only because there is no reservoir. So then the best thing is the gastrostomy. But of course, one thing you have to make sure is that the fundoplication has maybe, or there is no reflux. So reflux has to be excluded before you recommend or insert a gastrostomy. But otherwise, in a child like this where the feeding is quite difficult and who needs to be fed quickly and corrected the calories and the weight, you can go for a gastrostomy tube. Then after once it is, everything is done, where the child is back to normal, if they have undergone a renal transplant and everything, you can just pull it out and it will close on its own, or you can just put a stitch. So those are the things. Any questions on this? So you can see it's a child with of a different age, again with a chronic disorder, having malnutrition. Any questions?
No,
Can
sir.
you hear me?
Yes, sir.
Anything, any questions you want to?
No questions, sir.
Right. Okay. Can we go to the next? Okay. Okay.
Fifth scenario.
Okay.
A
Right.
7-year-old girl who was diagnosed to have type 1 diabetes mellitus is being investigated for poor growth. She weighed 15 kilogram, which is less than minus 3 SD. BMI is 12 kilogram per square meter. Mean BMI for 7 years girl is 15.75 kilogram per square meter. First question, explain the possible
Right.
causes for this. Second question, briefly outline the plan of the management. My answer is for the first question, type 1 diabetes mellitus is an autoimmune metabolic disorder which results in hypoglycemia. There is absence of insulin or very low level of insulin due to beta cell destruction. Therefore, peripheral tissue glucose uptake and energy production is reduced. For energy compensation, the adipose tissue lipid, adipose tissue in lipid, adipose tissue lipid, glycogen in liver and skeletal cell, skeletal muscle catabolism, glycogen in liver and skeletal muscle catabolism will occur. Therefore, nutritional storage will be less for growth of the child. As well as the diabetes patients are immunocompromised, they are more prone to get the recurrent infection. Recurrent
Right.
infection
Okay.
also
Go ahead. Go ahead.
recurrent infection also cause for the weight loss due to high basal metabolic rate due to maintain the immunity. Also, she may have other associated autoimmune disease such as hypothyroidism and celiac disease, which are also cause for the growth retardation. In second question, management aims are regulated carbohydrate intake, matching growth needs and activity. Insulin regime designed around child and family needs and abilities. Continue monitoring of control. Continue monitoring of control of glucose, insulin, usually home blood glucose monitoring. Immunization for influenza and pneumococcal vaccine. Another one is monitoring for the complications such as eye, skin, and extremities. For the advice for the family, understanding of blood sugar control, good control can reduce the complication, lifestyle modification, adult diet and insulin according to the activity and illness, recognition of importance and treatment of hypoglycemia, recognition, importance and treatment of hypoglycemia, advice for the continuing advice for the family, how to store insulin and how to inject it and disposal of the syringe, inform about the disease to alcohol, disease to school teacher and do immediate action on hypoglycemic state at school, regular follow-up for fasting blood sugar, HbA1c, urine albumin, creatine ratio and lipid profile and growth of the child. Other investigation we have to do is investigation for any infection such as full blood count, ESR, CRP and urine full report and urine culture, and for the thyroid function test, for the thyroid function checking. That's all, sir. Hello, sir.
Okay. Anything else? Hello.
Yes, sir.
So what are the problems here?
She is this girl having type 1 diabetes mellitus newly diagnosed, and she is underweight.
So it is wasted because we have not given the weight for age here. No, after 5 years we don't have weight for age, so it is wasted. So it's a wasted child who should have 15 kilos or almost 16 BMI is now only 12. So why is this happening?
Because of the diabetes mellitus, type 1 diabetes mellitus.
What is the property? What is the main function?
ketone body formation.
Ketone body formation. So in a normal people, do we have ketone bodies in large amount?
No, sir. Lipolysis is happens.
Huh? No, not lipolysis. Go to the next slide. It is mainly an building, construction of the body. It is not a catabolism, it does not break down. So it always try to hold everything in the body from carbohydrate. It is actually a hormone which is important in energy metabolism. When you say energy metabolism, it is mainly deposition of absorption of carbohydrate, retention of carbohydrate, retention of protein, as well as retention of the lipids. So when there is high amounts of insulin, it will be, or the correct amount will help to build the body. Now what has happened here is that the patient is not taking enough amount of insulin. So as a result of that, he may be losing his glucose. Now you have not said that he would have lost his glucose in the urine. We know when the renal threshold goes up, you will have glycosuria. So that means you are losing your carbohydrate. So if you give 100 grams of glucose from the mouth, but if he loses 50 grams in his urine, then he is left with only 50 grams for his functions. So similarly, the lipolysis will take place. Then the protein lysis will take place. So there will be non-building of protein. So that's the main reason. So on the other hand, sometimes what you will have is they can become obese even, because especially adolescents, 12-year-old, 14-year-old, 15-year-old who want to go out with the friends and eat, and they don't want to have hyperglycemia. So they will take more than normal insulin. So if you are recommending them 10 units, they will take 15 units. They may take 4 or 5 times instead of 2 or 3 times. So the other complication is that they can become even obese. So obesity as well as wasting are two things that can go in hand, where due to poor utilization of insulin, either it can be low insulin or they are injecting high amounts of insulin. Okay, go into the next page. Next slide. Okay, so management, so regular carbohydrate. So you have to take a proper diet. So how do you give the carbohydrate? How do you tell the parents to take or the child to take? Anybody?
Part of the plate of carbohydrate, rice. If taking rice, part of the plate.
1/3 of the meal.
Or carbohydrate, no, you will give as carbohydrate exchange. Now what we have to mainly maintain is that you have to give less amounts of fat, calculate the total energy requirement, and then we take about 55% of that to be of carbohydrate. So we'll say child is having needed 1200, 1100 kilocalories. So 55% of that would be 1000 kilocalories, then 55% would be 550 kilocalories. So then we take the 550 kilocalories, we will identify how many grams of carbohydrate is needed. How do we find out that? If we say, okay, 1100 is his kilocalorie requirement per day, we are going to give 55% of that from carbohydrate, 1000 kilocalories, 55% as carbohydrates. So that works out 550. That is calories. So how much of carbohydrate we need from that day?
We have to multiply.
Or glucose. Or, So how much of grams of carbohydrate would give 550 kilocalories?
According to the glycemic index of the food that we are eating.
Glycemic index. Glycemic
Calorie amount divided by 4. Sir.
4. Because 1 gram of carbohydrate gives 4 kilocalories. So then 550 kilocalories would be given by 550 divided by 4, which would be about 100 or something. So we'll say 100, 15,
27.
we'll say 125, right? So 125 kilocalories they need. So then what we do is we identify a portion size which would have 15 grams of carbohydrate. For example, a slice of bread, a half a cup of rice. So then we tell them, okay, then we divide it by 15 to see how many portions are needed. 15 gram carbohydrate, how many exchanges are needed. So we'll say, okay, we'll say 150 kilocalories it came. Then when we divide it by 15, it comes as 10. So we can say, okay, today you can eat 10 carbohydrate exchanges. So that means 1 slice of bread equals to 1 to 5 string hoppers equal to 2 hoppers or whatever like that you can give. So when you say that, then you will divide that. Okay, this now he can take 15 for the day, no? So then he will say, okay, you take 5 in the morning for breakfast, 3 for the lunch, 3 for dinner. Then you ended up with 11 and then you have 4 more where you can take it as 3 snacks or whatever. So that way we will give the idea of how much from a measured way he should be eating. Then you give the list of food items. As I said, half a slice of bread, 1 slice of bread, sorry, half a cup of rice, 5 string hoppers, 2 hoppers, 1/2 dosa, chapati, or whatever, that amount you will give. So then he can decide how much he should be eating, from what, based on the menu. Now he decides, okay, this morning I'm going to eat string hoppers. So then I can eat 20 string hoppers or whatever, or 20 string hoppers and then 1 piece of potato. So then my 5 carbohydrates are done. So like that for lunch. So like that he can decide his menu, but he has to count, and flexibility is given to the patient or the parent. They can eat whatever they want. We are just monitoring their quantity. So that's why even in obesity management, in anything, you should not be telling food should not be taken. No, they can take the food, but they should take it in the proper quantity, proper volume. That is the most important part. Whether it's diabetic, whether it's obesity, anything, the quantity is the correct thing that they should be eating, not the type of food. Very rarely. Only in allergies, of course, you can say don't take this food. That is also if there's very severe allergy. But otherwise, usually food can be eaten. The important message that you should get to your head is that you should eat only the correct amount. Next page. Next slide. Yeah, advise family, all that. And then you have to supervise, and especially this child, you have to make sure that the correct diet is taken and the correct insulin. Now, in children, you will calculate the calories and then you will increase the insulin. Now, in adults, of course, they have finished now. I told you, insulin is an anabolic hormone. So if you don't give the correct amount of calories and then to regulate that calories, you have to increase, because in normal physiology, a growing child will eat adequately, and then to match that, the insulin will secrete increasingly. But in adults, of course, what we do is we calculate the insulin and we match the diet intake to get the proper blood control. So then we increase or decrease the food amount we are eating, the adults are eating. But when it comes to children, we give the correct amount of food because they have to grow. And then once you are given that correct amount of food to get the correct glucose control, you will either increase or decrease the insulin. So those are the diabetes in older and younger age groups. Okay, any questions? Is that okay?
Yes, sir.
Right, can we go to the next one? Next presentation. So you have to leave the presentation. Or leave sharing. Next person, please.
Hello, sir.
Yeah.
The first question, sir.
Yeah.
Verify. A 6-month-old baby has been referred to a pediatric clinic by the MOH for failure to thrive. His growth chart shows that his current weight is below the -3 st line, red
Yeah.
zone. Mention the additional information that you would gather before making a dietary intervention. And the second question is the birth weight of the baby was 3 kilograms and he is being breastfed. He has been quite well up to now. Describe the plan of management for him.
Well.
For the first one,
Yeah. Okay.
We should
Right.
get history. There, we should ask when the problem was first detected and any identifiable reason around that period. And if any illness, for how long and how it treated properly, investigations and result, and what is the progressive or not, and how severe, how did the child activity and get affected, and what do parents attributed the problem to. Then feeding during the illnesses, and the failure to thrive may be due to other diseases, so we should exclude all the diseases with the systems. So in GIT, we should ask the appetite and as this patient babies breastfeeding, the sucking and swallowing easily or recurrent any aspirations, and attachment and positioning, about the attachment and positioning, and irritable during food and vomiting, in relation to meal, and how often, what was the content of the vomiting, and was it a projectile, a blood stained, and any mucus altered blood, diarrhea, watery diarrhea, or any hysteria, and greasy, frothy, foul smelling, any diarrhea, and whether there was constipation, it may shows a Hirschsprung disease, and respiratory system, cough, and frequently with wheezing, asthmatic patients, and persistent loose cough with purulent sputum, and whether there was fever, and any contact history of TB, any recurrent respiratory tract infections. Cardiovascular system wise, whether a known patient with congenital heart disease, and any investigations done or not, and uh, any surgeries done, and with the head sweating and the poor feeding, and cyanotic spells, and in the chronic liver, for the chronic liver disease, icterus, pale stool, and dark, about the dark urine, and urinary tract, recurrent urine tract infections, any features of urine tract infections, and past history of hematuria or facial swelling, any ENT, ear ache or ear discharges, and muscular system, joint pains or rashes.
Now, muscular system problems is you will not see. Musculoskeletal problems will not be there. Okay, go down.
Then the endocrine.
Again, diabetes mellitus is not a problem in this age, very, very, very rare.
6.
Then appetite, thyroid, okay, maybe, but not very much. Anemia, okay, could be there. But malignancies, again, it's not a cause for failure to thrive in this age group, no. So the common things in this age group would be where there is now you have to see the growth chart and see whether the child had been growing nicely and what age, as you said, it will begin to fall, right? So then if the child had been feeding nicely till about 3 months, 4 months, and then begin to gradually fall, it's mostly inadequate calories coming from the mother's milk. And then of course, if there is a abrupt fall, then but having said that, you have to also remember whether it could be something like a UTI, which is the commonest cause. Then of course, the other conditions like heart failure, congenital heart diseases, maybe recurrent respiratory tract infection, especially if there had been other brothers or sisters at home, where they may go to school, contract, and this child also get. Then episodes of vomiting could be another reason. Then other congenital problems like renal problems, like any electrolyte problem, especially you may have heard something called Barter's disease, which you don't have to remember that much. But that type of a thing, then there can be liver diseases with jaundice where the absorption of fat is not taking place. And the other important thing is cystic fibrosis, where they may be having everything, but of course no proper lipid digestion system, and because of the pancreatic insufficiency, so they will lose a lot of fat in the pancreas. In the stools. So that is the most other important thing. But if the child had been feeding right from the beginning, well, of course, then there is not been an issue, but if it is a later thing. But if these things are mostly that you begin to suspect later on, then of course, which is very rare in this country, celiac disease, but that will really clearly show with the time of starting complementary feeding that will happen. Okay. So you should not be putting all causes. You have to make sure that the common causes for this age group is what. So any child who is malnourished, you have to see whether they are getting enough food. If they get enough food, whether the child is retaining enough food. If there is no retention, there is a lot of vomiting, then there is a problem. If they are getting, then whether retaining, whether they are being digested properly. So because again, there is a pancreatic insufficiency, that type of a thing. Sometimes they will digest, but they will not absorb. So then you have to see whether there is jaundice, liver disease, or there can be a past history of diarrheal illness where the enterocytes are damaged and it is taking a little time to recover, that type of a thing. Then of course you have to go and see whether they are having very quick passage of stools, because there can be increased gastric motility. So the child will pass about 3-4 times bowel motions. So there is no time to absorb, although digestion takes place. Then the other factor is whether there are any factors which increase the body demand. For example, there is a UTI where the immune system is functioning. There is a heart failure. There is respiratory problems. So his respiratory rate is high. So he needs more energy for that. So the normal percentage of energy which is a normal child requires is much more in this child. So the amount of food that will go for his growth and development, or growth and putting on fat in the body, will be less. So that way you can find out. So whether there is food available, whether there is food retained, or swallowing difficulties. Sometimes they may have swallowing difficulties, like in cerebral palsy children, non-retaining, non-digesting, non-absorbing, loss of food from the gut quickly, and then increased demand. So that is the way you should be lining up, and you have to find out for the particular age group what is the best, what are the most possible factors, rather than putting down all the factors that is available in a textbook. So then of course, if usually at 6 months, if there is drop in weight, or 5 months, then of course breastfeeding technique, I don't think you have to teach very much, because they are all learned. If it is in a 1 month old, 2 week old baby, the breastfeeding technique and inexperience, unskilledness will come in. So letdown reflex in a 6-month-old baby's mother is actually not an important thing. Positioning, that type of thing is not very important, because for 6 months she would have by now learned, because breastfeeding is actually a natural process. We are trying to give a little bit of more scientific way in order to initiate breastfeeding quickly. But after 6 months also the mother can't breastfeed, that means something else could be wrong rather than the natural process is. Then of course mother's IQ and things would be a different matter, or she could be a psychiatric illness or something. But usually that's why. Now this type of things will not be quite appropriate for this context. So you have to make sure that you tailor your discussion to the correct. Okay, go down. Further down. Yeah. So what was that? So then of course you have to see whether how the child was breastfed and so on, when this faltering took place. Okay, go down then. Move. Yeah, so those things are important, consanguinity and things like that, because it can be a renal disease or something like that. You have to find out. So education of parents, income, those are important, right? Okay, then. Yeah.
Then the examinations,
Move.
there
So you have to do those things, find out, yeah. Correct. Examination to see whether the growth parameters, and of course to see the deficiency features, and then also to find out the underlying abnormality, whether there is there, which contributes to the failure of the driving of the failure of the growth of the child. Right, okay, then because koilonioikia and all you don't see in a 6-month-old baby.
Yes, sir.
Palm erythema, all those things, clubbing, unless, okay. So it is, well, what you have to learn is to take the relevant things for this particular age group, rather than you have written everything from a 1-month-old baby to a 99-year-old person. That should not be the way. Right, move. Okay.
For the
investigations, you have to do it in a relevant manner. So one of the first investigations in a child like this is to do urine culture and see whether there is any UTI. Then of course, yes, you can do the full blood count and see where the anemia, but of course at this stage, there will be iron deficiency if the child was not supplemented, even if it is a term, well-nourished mother's baby. So you have to give iron. Okay, then.
Then, sir, for the treatments, this would be a multidisciplinary approach, and
Well, what do you mean by multidisciplinary approach for this? What do you mean by multidisciplinary approach for this child?
Because failure is affected, so here patient is below the -3 SD and without any complications, so we can manage the patient outpatient, but for the management we have to see the cause, underlying cause, and we have to correct the cause, and for that we have to collect all the specialties, and for the best care we could for the multidisciplinary approach.
Well, I don't think we have to have actually multidisciplinary thing unless we identify a particular problem. If there is a cardiac problem, yes, cardiologist. If there is a renal problem, maybe the help of a nephrologist. But overall, I think the primary management here is to feeding. So this can be managed by general practitioner very easily. So initially when you have the weight, you also have to get the length and see whether what is the weight for length of this child, and then categorize it whether it is a moderate acute malnutrition or a severe acute undernutrition. And then you will, who is exclusively breastfed or whatever, the weight begins to drop. And mostly it is nutrition related rather than other things. But of course, having said that, you have to go for that. So then you start on the, see the diet, correct the dietary while awaiting your investigations. You may be giving supplementation of minerals and vitamins. As you all know, the multiple micronutrient sachets are given at 6 months. Do you know that? MMN? Hello?
Sir.
Do you all know MMN is given? Can you hear me?
Yes, sir.
Yes, sir.
Yeah, what is MMN? What is MMN?
Micronutrients.
Huh?
Micronutrients.
Yeah, multiple micronutrients. There are 3 main micronutrients. Iron, zinc, and vitamin A should be there. And here it is given for 2 months, 60 days from 6 months. Then again for another 60 days starting from 12 months, and for another 60 days starting from 18 months. So like that. So anybody who is not getting that, or sometimes if their appetite is poor, they are not eating, then you have to give medicine or vitamins as a separate iron and multivitamins. So when you are given as 2 separate things, always make sure you keep adequate distance, because if you give iron with, we'll say, zinc or copper, zinc, then the interaction will not help the zinc to get absorbed. So you have to keep at least about 2 to 3 hour gap between such things. Similarly, if you are giving calcium, you should not give iron immediately. You have to at least have 2 to 3 hour gap between. So that way you have to do, and then you give the diet, and then treat the child. Okay.
Here, sir.
How often do you get them? Yeah.
So here the patient should contribute weekly as the outpatient, sir.
Sorry, I did not follow you.
So here the patient should outpatient manage. Do we have to manage?
Yes, you can manage this patient as outpatient.
And follow-up plans.
Manage as what?
Weekly. Sir, hello, sir.
Yeah, we at least maybe weekly, or maybe in 2 weeks time you can get them for the first assessment.
Okay,
and if the child is gaining weight well, then you can do it once a month.
Okay, sir.
Yeah, clear?
Yes, sir.
Any questions on that? Anybody? Hello? Any questions?
No, sir.
Can I have the screen? Can you close it? Hello?
Hello, sir.
Can you close the screen, please? Yeah. So if I quickly discuss a little bit of as a summary. So childhood malnutrition, you can have malnutrition is wrong nutrition. It could be either deficiency or excess. So because earlier we said malnutrition, we thought it is equal as undernutrition. But today we see that even overnutrition is a big problem, which is also wrong nutrition. So when we have nutrients, why do we want is mainly for the basal metabolism, then digestion, Then for day-to-day activity like going on to the toilet, going and eating, things like that. Then if we have more energy, extra physical activity, then for the child, it needs for growth. And if there is anything in excess after using for all these, then they will have for storage. So that's why obesity is a excess of storage. So then when it comes to that, they will also have the optimum growth happening from the height as well as the weight and muscle point of view if all the balanced nutrients are there. So then if there is a deficiency, one by one, these will be lost. So they will become thin, then they will become stunted, not growing. Then the child will become lethargic. Then he will be more or less confined to one, saved for that. But when they have excess energy, then you can see some children are really, really boisterous running around. Then they will be because they have more energy. Then the growth will take place, storage. And sometimes what happens is, when they excess storage, of course, then again they will become lethargic and stop physical activity. But this is the sequence where if we are given energy, how the body will use it step by step. Is that clear? Hello?
Yes. Yes, sir. It's clear.
Do you all hear me?
Yes, sir.
Yeah. Right. So then we have the macronutrient problems. We have the micronutrient problems. So then this is the cutoff. This is the classification. Now under 5 years, you get weight for height. Above 5 years, you get BMI for age. And then the moderate undernutrition is if anybody less than -2, either BMI or weight, you take them as undernourished. If it is less than -3, it is severe, and the other group is moderate. Overnutrition is a little bit different. In BMI, anything more than +1 is taken as overnutrition, and more than +2 is obese. In weight for height, of course, you take +2 as overweight and +3 as obese. So this is what you have to remember. So this is the basic way of defining undernutrition from a protein energy malnutrition. Then of course for the long term you have height for age, but we don't use weight for age as a diagnostic tool for the assessment of nutrition status. But it is just only a quick reference, because for the midwife it is very easy. Weight will drop very fast if there is a problem. Then you have to see whether it is a short-term, long-term drop. So for screening, you do either height for age or weight for height or BMI for age. So this is the chart which you are familiar with. So you can see below -2 severe, -3 severe, moderate. This is normal range. This is overweight range, +2 to +3, and above +3 is obese range. So in the BMI chart, below -2, you can see wasting. -2 to +1 is normal. +1 to +2, obese, overweight, and then +2 or above is obese. So undernutrition, it can be primary malnutrition or secondary. Primary malnutrition, we said that the availability of food is not there. So it is actually for dependent people, elders, children, institutionalized people who depends on somebody who brings the food and give it, is primary malnutrition. Secondary is you have the food, but there is a disease. As I told you, there can be a swallowing difficulty. They are not retaining, they keep on vomiting. Their digestion problem. Then there is absorption problem. Or the demand is high. They have a respiratory tract infection or a heart failure. So they need more calories than the others. So that is secondary malnutrition. We'll skip these. So in physiology, I told you the child is now, if there is malnutrition, they will try to preserve energy. So if the heart rate is going at 100 or 80, it will come down to 40 or 50. So you can cut down the energy. The respiration may come down. The liver functions, protein synthesis, all will come down. So all these functions will gradually come down. And when there is no substrate, insulin will come down, because insulin is needed for, it is now no function because there is no calories. Then the insulin-like growth factor will come down. Growth hormone, which is a steroid, it's a stress hormone will increase. Again, for the metabolic functions, thyroxine is needed. But when the metabolic functions go down, thyroxine has to go down, because if there is a lot of thyroxine can stimulate the metabolic functions. Now you know high thyroxine will stimulate the heart rate, and then but there is no energy to function. So somebody who had energy for 2 days will now, if the heart rate increases, will die out of 1 day. So the nature has taken care of all these processes. So the whole function of the body will go into a slow state. So the management, we discuss history, anthropometry, and the basic investigations. So severe acute undernutrition, we have to detect. So if there is severe acute malnutrition, there can be complications. The ones who are having no complications can be managed at home. Now the child we saw did not have any problem, but only thing you can manage at home. So their appetite should be good, no clinical illness, very alert, and whenever you give the food, they will eat. So you give the feeding, you give the basic health care, and how to prepare. We have problems. If the child is not eating, respiratory infection, anemia, high fever, infections, all this you have to correct. So you have to admit them, and then you have to give medical care for the problems, and you have to give therapeutic feeding, so special feeds, and then you do it. And when the child is still maybe mad, but when the complications are over, you can manage them as an outpatient in the hospital. So in the acute phase, you look for hypoglycemia, hypothermia, dehydration, electrolytes, and infection. So in the initial stabilization week, also you start on the micronutrients and feeding. So these are the 7 first things you will do. So these will stop in the 1 day or 2, then the others will keep on. Micronutrients, you give everything other than iron in the initial phase. So once after about a week or 2, you start on iron. We have kept that. So in patients, you can have special formulae like F75. This is 75 kilocalories containing in 100 milliliters. The important thing is now in these children, their gut is disused. So you give a large diarrhea. So you have to give small amounts of calories with a less calorie dense food item, and then correct it. And then you have to give micronutrients. So when you are gradually things are improving, he needs more and more energy. So when you give 75 that type of a solution, he will be having distension. Then you have to increase the calories. So then you increase this into F100, where 100 kilocalories in 100 ml. Then you gradually increase. Now here we were giving about 70 to 80 kilocalories per kilogram per day. But that is not be enough, no, because we know at least he needs about 110, 120 for normal. You can go even up to about 220 kilocalories per kilogram. And you calculate to the current weight of the child. So if the child is now 10 kilos, you calculate it to 10 kilos. So he can go even up to 220 kilocalories. So that way you increase the calorie in there. So then gradually now the calorie here will become difficult to give, because this is also a low calorie density compared to calorie content. Now when you are feeding these children, you have to see whether the child is getting better. So the golden rule is if the weight gain is more than 10 grams per kilogram per day. So if the child was 10 kilos yesterday, today if he has become 10 kilos and 100 grams, then it is good. But he has become only 10 kilos for 1 kilo, 10 kilos. So that means he has gained about 3 grams per 10 kilos. So that is not good. So anything between 5 to 10 is reasonable. But if it is below 5, then of course you have to look whether something is going wrong and have to investigate. But this is the usual plan. So then you have this preparation. You can make this F100, F75 even in the ward. Then the ready-to-use therapeutic food, we are very, very high calorie dense. And you can see, now earlier we were talking 100 grams or 100 milliliters containing 100 kilocalories. Now here you can see about 100 grams contain 500 kilocalories. Now this is 92 grams, 500. This is 100 grams contain 527 kilocalories. So that's a very, very large amount. But you have to also remember, when you are giving this type of food, you have to give large amounts of water. Otherwise, what will happen is they will have dehydration. So then the other things like catch-up growth, then sensory stimulation, prepare, follow-up have to be done gradually. So you will stimulate the child, because I told you, you have to keep the child happy also. So then that is where you stimulate the child. Otherwise, he will be a lethargic, unhappy child. So you play activity, those are important. Then on the other hand, you will then by about 2 weeks, because first day you feed the child and don't expect a weight gain on the second day. It will take some time. It will take at least about 10 to 15, at least 7 to 10 days. So in the second week only, you should begin to see a weight gain in these children. Right? So the appetite good, medical complications controlled, minimum edema, you can discharge them. So you started with the weight for age less than -3. You keep on feeding them. They become ma'am, and now this is the child is normal. But still, they are vulnerable, and then they can fall back if you don't follow them up. So you still keep on feeding them. Now you stop the therapeutic food at this point. You give the normal homemade as well as Triposha-like supplementary food. And then when the child comes to the mind, charge them from follow-up, and you wait till they come up to this point, then the chances to fall down is very, very less. Okay? Is that clear? Hello?
Yes, sir. It's
Right?
clear, sir.
Any questions? Right. So, nutrition on the other hand, actually BMI. So if the body fat is more than 25% in males or more than 32% in females, you will call them having high body fat and they are obese. And usually the fat content measurement is a little bit difficult. So you can use the BMI as an indirect measure of that. So that is how the BMI came there. So I told you this. So then I told about obese and long, tall. Then you consider them and you look for signs of this. These will be pretty obvious. But if it is tall obese, of course, it is mainly food related. Either because of a disease they are eating food, or there is a normal person who has got into the habit of eating food and not doing very much and burning calories. So they have retaining calories. So this is the usual form. So it can affect any organ. As I told you, acanthosis is an important sign that you can't ignore. And what are the management? Reduce weight, treat any morbidity, and psychological adjustment is very important. So you do fasting blood sugar after 12-hour overnight fast, lipid profile, ALT, AST, OGTT, the blood sugar should be done. So this is actually, you may come across 75 grams in some books, that is anhydrous glucose, that is glucose without water. But usually you always get one glucose molecule having a water molecule with that. So if you get 75 grams of glucose, there will be equivalent amount of, or matching amount of water. So that's why in the market is the monohydrous glucose. So you have to make sure that the water value is also added to that. So then management behavior, as you said, dietary plan, change in activity, increasing physical activity, reduce sedentary behavior, provide psychological support. So all these things will come in the management behavior modification. So it's common sense that you organize them mentally. But what we do is actually, now you all know the food-based dietary guidelines. So there are food types of food, bread, vegetable, fruits, milk, meat, like that. So you have this guide, and on that you give portions. As I told you in diabetic patients, here also you give somewhat what you don't is the most important. So they can even eat chocolate. There is nothing. But they should not eat bars and bars of chocolate, but only a small piece of chocolate. So like that we will, so you will give this chart, then they will know, okay, they have an 8-year-old child, they should eat only this amount per day. So then they will know what is meant by a portions of starch. So one slice of bread, half a cup, 1 cup of porridge, 5 string hoppers, 5 hoppers, or like that. So then they will know today I am going to eat hoppers, so how much this child should be eating. So like that they can work it out. So then activity improvement, sedentary behavior, or like we said, and there are 2 guidelines actually for physical activity below 5 years, and this is for children above 5 years. So 3 main things are there. That is the sleep time, sedentary time, and physical activity. It's very, very important that you sleep these things, because sleep is also very, very important. You can't say that you have to sleep less amount, no. And it has to be slept in a proper way. For even y'all, you should be sleeping during the night time a correct amount, at least from 10 to 6. 4 a.m. in the morning is the best, and minimally even a day, because if you do more, not sleep that much, your productivity will go down. So you will say, I have studied for 16 hours or 18 hours, but of course it is not as good as a person even studied for 10 hours a day. So you have to bear that also in mind. So then the sedentary time, because you can do a lot of physical activity. So this has to be limited. This has to be increased, because physical activity, when we say, we always get into our mind either cycling or running or jogging or something. No, even if you just stand and wait, that is also physical activity, because a lot of muscles are working. But if you just sit on a chair, you're not doing anything, because the chair will bear off your body. You can spend time. So these 3 all should be there. And if you go through the CHDR, you will see even for children under 5 years, this has been now included in the new CHDR. So these are the times to be slept, and these are the advantages of and disadvantages of sleep. So then, of course, you should sleep properly. You can't just sleep. That's a good bedtime, wake time, regular time. You should have a good exposure to sunlight in the morning, and you should have a good dark room. You should not go hungry to bed. You have to eat. You should not eat things that will prevent you from sleeping, like coffee. And you have a relax. Don't keep any of your screen devices close to you, because especially the radiation is also very bad. So even regular daytime exercise is very important. That will also help you to have a nap. So even at this juncture, doing about 1 hour or half an hour at least good vigorous physical activity will improve your productivity and will be able to face the finals very well. So these are the older children guidelines. And then again for them also limit. For obesity, it contributes as well as it can contribute. It can also have impact, especially the screen devices, on the brain, certain chemical secretion. So how do we prevent childhood obesity? We have to give them the correct amount of food, not more, not less, and we have to see whether they are growing properly. So this is how we have to see whether we have to see whether these are correct growth or not. So you have to match it always with the weight for height, because I told you weight for age is not a very good indicator. You have to see whether the person is growing correctly to the height of the individual. So you take it that way. So then you go to the grown his weight up and his height also has gone up, whereas this one has grown in his weight, but he has hardly grown in his height. So for the same height, he had been putting on a lot of weight. But here, for asthma, the child A was putting weight as well as he was growing tall. So you can see A is with, this is the weight for length chart. So that is the important. So the important thing is regular growth monitoring is important because it will prevent undernutrition as well as overnutrition. So any questions? So growth monitoring is very important, where you will see the underweight will also be picked up early, and then the overweight will also be picked up early, and always match with the weight for length chart or the weight for height chart or the BMI in the older children. Any questions?
Yes, Professor Pujita, one question from me. I'm Dr. Angela. This portion charts you showed this picture, is it available wherever like
Well,
charts?
there is a booklet available. I will try to send the booklet. I will email it to you.
Yes, please. Thank you very much.
Okay.
And just about the micronutrient supplementation, I think you mentioned that. Where can we find that reference in the CHS?
Well, sorry, say it again.
No, the micronutrient supplementation.
Yes.
Yeah. So
there is actually there is a health ministry circular. What I
recent one or
is I will share it with you.
Okay.
I think 2017 or something.
Okay. All right.
I will send you the health ministry circulars.
Okay. Thank you very much.
Actually, I gave a lecture at the SLCP. I don't know whether you got it.
I may not have participated.
Okay.